This is the One Thing Podcast, and I'm your host, Dr. Adam Rindy. The One Thing Podcast brings together leaders in functional and naturopathic medicine to discuss actionable information that may unlock puzzles in the areas of gut health, brain health, metabolism, and longevity. Please note, these episodes do not replace the opinion of your doctor. They are not intended to diagnose or treat any condition. Please discuss this information with your provider and discuss your own unique personal health history before adapting this information. Please subscribe to our episodes so that you can stay on top of the most current information in these areas of medicine. Hey everybody, welcome to this week's episode of the One Thing Podcast. This is Dr. Adam Rindy. I just had a delightful conversation with Dr. Mandy, who's known as the IC Healer. You can find her work at ichealer.com. She is a doctor of clinical nutrition and someone who has really taken upon herself to educate the public and address patients with interstitial cystitis and painful bladder syndrome. We had a great conversation where we went into many aspects of the experience of a patient who has interstitial cystitis or painful bladder syndrome, the disruption in the body that might be taking place, such as issues with mast cells and issues with gut permeability or gut dysbiosis or gut imbalances. And we also go into issues with oxalates, which is an interesting component of the struggle with IC and painful bladder syndrome is dealing with oxalates from the diet. And so we talked about that and various other pathways about how to organize and heal from these conditions. Very enlightening to hear her dietary approaches and nutrition approaches, also her strategies and prioritizing what is important to focus on first, and also how she incorporates other aspects of these imbalances, such as thinking about fungal causes, mycotoxin causes, and other environmental chemical triggers for these bladder issues. So with this episode, I think you'll find that you'll have a clear understanding of what the answers are for addressing these conditions and some clarity about how to proceed to get help. There are lots of conventional options and many different functional medicine and naturopathic options. And I think it's important to hear from an expert to be able to understand where to start your journey of healing. So I hope this is helpful by those means, and it helps people get clearer about the path forward with these really troubling conditions that can be debilitating and really limit quality of life. At the end of this episode, I believe you'll have hope to move forward on this path with hope that there will be better days ahead. So without further ado, I welcome you to the next episode of the One Thing Podcast. Dr. Mandy, welcome to the One Thing Podcast. I'm delighted to have you here with me today.
Thank you.
Yeah, so I wanted to get started a little bit hearing about the path you've taken. I think it'd be really helpful for our audience to hear about what a doctor of nutrition is. I was telling you offline that I have been so impressed with your profession and your ability to synthesize this amazingly complex world of functional, integrative, naturopathic nutrition and just kind of pull it all together. So I would love to kind of hear you talk about the profession in a little bit and kind of inform our audience.
Sure. So, we'll backtrack because in my undergrad days, I actually was a registered dietitian major. So that's how I started my career, and I never actually finished that. I honestly, what made me not want to do that was when I was told that I'd be working in a hospital and doing tube feeding. And I was like, that's not what I'm trying to do here. So I actually left that profession and went into engineering, of all things, and graduated as an engineer in packaging engineering, worked for food companies, marketing, candy to children, which was not exciting for me. So I don't know if you knew that about me, but so I do have an engineering degree. I worked for 5 years, miserable job. And I think what really initiated me to follow this career was my own health issues, honestly. I've always been interested in nutrition, but primarily from a weight loss perspective, because most of my life I struggled with my weight. Really just was one of those girls who always felt like if I even ate a slice of pizza, it was going directly to my hips kind of situation. So that kind of got me into the fitness nutrition, and I started teaching fitness classes. I'm a fitness instructor, still do fitness instructing. And then I started to do more of the fitness nutrition. I got certified in that. And that was interesting for me, but it wasn't until I was diagnosed with IC, probably we're looking at 13 years ago now, is when I really started to want to dive a little deeper into the biochemistry of my illness and understanding where things went wrong. I wanted to know the physiology, but mostly the biochemistry and how I could reverse it naturally, because the only thing that they were offering me was obviously, medications and surgery. And I wasn't at that age. I was so young. I was like, this isn't the life that I was expecting I was going to have to live. And so I feel like that's where, I went back into nutrition, so I already had the background as the dietitian, but I went back and it was clinical nutrition that I really want to get into. I didn't want to just do meal planning. I didn't want to, and I don't want to say that that's all registered dietitians do, because they do some clinical nutrition as well. It's just that was when I was in college, that's what they were teaching me. And so when I went back and started to study the clinical nutrition piece of it, was really what I was like, this is what I've been looking for. That's where the doctorate is just basically, it's a doctorate degree in clinical nutrition. So you can have a master's degree in it, which is what you need, the minimum of master's degree in order to get the certification through it's called the Certified Nutrition Specialist, CNS. You have to have a minimum of master's, but I decided, because I already had a master's in biology, because I went back and got a master's. So I went and said, well, I'm going to go ahead and move forward into this, and got the doctorate. So.
Yeah. So I think there's a famous quote that the doctors of our future will be prescribing nutrition, and actually you are, I guess, the doctor of our future. It's here now. It's and I know you're not considered like a medical doctor or what have you, but it's just really interesting that we're here. And when I hear some of the conversations that doctors of nutrition are having, you're doing really deep work. It's not just putting people on a diet. It's so much more.
Yeah, absolutely. Because, what I realized was diet was highly individualized. I learned that the hard way with weight loss, because there was just, people were, certain diets that were supposed to be great for your weight loss efforts weren't working for me. And I didn't understand why. Now looking back, I know why. Now I kind of understand that my physiology, my biochemical pathways are very unique to me. And that's what I really like about this field. It does really help you uncover, each individual's unique needs within their own body.
Yeah. Okay. Well, I'd love to frame our conversation a little bit more, because we're coming to you today, seeing you as such an expert in this area of IC, interstitial cystitis. I think it's important for us just to kind of go into an understanding of the genitourinary system, just like an overview of how things normally are in the system, and as far as like frequency of urination, what would be kind of normal, and what the environment usually is like, and then contrast it to someone with interstitial cystitis. I think that would be a really good way to start our conversation.
Okay. Well, everybody uses the bathroom. Everyone urinates. The bladder is a very important excretory organ. And I think for a long time, medicine thought that the bladder was sterile, but now we know it's not. And I think that's really important to understand that we have a lot of new technology over the last 20 years with some of these, different PCR and whole genome sequencing, and they have realized that there is actually a microbiome in the bladder. So a lot of the diagnoses of urinary tract infections and how they did it with culturing is very outdated. I always use this example with my own patients because, sometimes a patient of mine will tell me, oh, I had intercourse and I got the UTI from that. And I always have to throw this back at them. That's not the reason why you got the UTI. Think about a baby who wears a diaper and they're sitting in their dirty diaper all day long. Mm-hmm. How come they don't get a UTI? And then when I tell them that, they're like, oh yeah, because it's like, they're sitting in their poop, right? So, if it was that easy to get a UTI, then they would be getting UTIs. And so I think that's where, I have to frame the conversation around dysfunction in your immune system. And there is definitely a very strong link to the GI tract and the bladder epithelium because they're connected. So, and they're very, very connected. In fact, I had written a paper in my doctorate that I was actually working with microbiome labs, and we were putting some information together. And I had found that the vaginal microbiome is actually very strongly tied to the bladder. So when they look at the genome sequences of the bladder bacteria, even though the population of bacteria is less in the bladder, they're there, but they're less. They're very similar to the vaginal. So there's definitely, I always say there's something went wrong with the gut and affected the vagina, and then now it's affecting the bladder because the lactobacillus that seeds the bladder are actually coming from the vaginal area. Mm-hmm. So if we don't have the lactobacillus, which obviously happens to a lot of women postmenopausal because of estrogen, lactobacillus species tends to decline. You notice postmenopausal women are also more susceptible to UTIs. Mm-hmm. So that's part of it. And then there's pH, vaginal pH. There's, sometimes that's off. And so then they end up getting these pathogens like Gardnerella is one of them that they tend to get a lot. And I think that also affects the bladder as well. So I think personally, I would say from what I'm seeing with all the information I'm getting from labs and just meeting all these people with bladder pain syndrome, and I see that the underlying problem I truly believe is coming from the GI tract. Yeah.
Okay.
Yeah.
Interesting. And that's helpful because I think we have a foundational understanding and access to information from the GI tract that much more so than we do from the bladder. Like it's easier to see what's going on in the GI tract for us and learn about it. So that's really helpful. So with the IC patients, with imaging and various other kind of looking at the tissue of the bladder and someone who's dealing with IC or painful bladder syndromes, what does it look like? Is it dramatically different than we would see in a healthy environment, or is it still really hard to kind of see the differences?
Most of my patients have very normal, when they go to the urologist, very normal bladder in imaging. But I'm not going to say that it's because it's normal. I just don't think they have enough damage there yet for it to be seen in the images. I think a lot of times that's very similar to somebody when they get a colonoscopy, or they look for, damage, but it's not there yet, even though they have the symptoms. Because I think, obviously you're scoping a certain area and you have to be able to see it. So those who do have abnormal imaging, it's very much looks like it's just red, a lot of redness. Almost as I always say, there's got to be some mast cell activation going on there because when they do the biopsies and you read some of the studies, they actually do find there is mast cell activation within the bladder. Yeah. So it's hot because when we think about mast cell activation, we think about histamine, we think about heat, we think about that burning. That's the presentation a lot of the people who do have the abnormal imaging, their bladder looks like. It's not necessarily ulcerated. That ulcerated piece, the Hunter's ulcers, actually only affects about 5 to 10% of the people with IC. And that's not my patient population. I don't have many of those. I have mostly the non-ulcerated. So that's why we have to also probably redefine this, because in Europe, they are redefining and differentiating between IC and BPS. So we probably need to go ahead and do that, even though it hasn't happened here yet. In Europe, IC is now considered the ulcerated form. They're the hunters. And BPS, or bladder pain syndrome or painful bladder syndrome, it can be used either way. So BPS or PBS is everybody else. That's 90%. That's me. That's most of my patients.
Yeah. It's interesting that we're talking about this because my last guest, Dr. Pimentel, who's a world expert in irritable bowel syndrome, highlighted a very important thing, that we're in a different era of medicine where these classic textbook cases that doctors all learn in medical school, where it's like just the most extreme pathology that we would use to define a disorder, we're no longer really seeing, because people are having access to earlier interventions or earlier care. There's more information for people to reach out earlier in the presentation. So we're kind of at a situation where we're not getting the clear-cut pathology to make diagnosis, until we get better diagnostic tools with, more microscopic imaging, or that are more commercially available and affordable. We're kind of still in this zone where it's like, we think you have this, it looks like it, but we don't have a clear-cut evidence.
Yeah, based on symptoms, which is how I was diagnosed as well.
Yeah, and I think we need to make that okay at this stage of, the information that's available, and the speed of research, and the speed of, social media, and all these things that we kind of have to not make that a poor practice anymore. It's like, we have to make some constructs with people's presentation, even if we don't see clear-cut pathology.
Yeah, I agree.
Yeah, and so a patient that would be dealing with IC or painful bladder syndrome, or we've been talking for 13 minutes. Like, what would they be going through right now if they were in a full-on flare in this last 13 minutes?
Oh, gosh. It is a horrible, horrible condition. I just have to tell you, speak personally. It is, I could describe it as burning, pressure, urgency, like you have to run to the bathroom, leakage, frequency, sometimes retention, so it can go either way, pelvic pain, spastic, griping, hot. I think the big one is burn. That's the big one I hear a lot, and that's what I had. It can come on at night. It can go on during the day. You can wake up with it. You can be fine all day and have it at night. I do have a theory behind why it gets worse at night. And sometimes it's very frustrating to pin down, like the schedule. It's not really a schedule, but I will say a lot of times it does get worse before menstruation. And there is definitely a histamine connection to that, and diamine oxidase levels tend to change right before menstruation, and then progesterone is also tied into that. And so I think with the hormonal fluctuations, it can get worse during certain times of a woman's cycle. Oftentimes it goes into remission during pregnancy for many people, not everyone, but a lot of that is also tied to increasing levels of diamine oxidase that occur during pregnancy. There's a very strong histamine. So when you think of histamine burning, that's a lot of what this is about. For me, I had another layer of urethral pain. So like almost like I would feel like I was urinating knives.
Wow.
Knives. And then I had bleeding, and some towards the later stages of when the lining of the bladder urethra becomes so damaged that your body can no longer repair it. I had bleeding. And it wasn't hematuria. It wasn't like your typical blood coming from the bladder. It was literally from the tissue of my urethra, because I could literally squat down, look in the mirror, and I saw the blood dripping out. So something was cutting it. And that's kind of how I tied that into the oxalates. Because I really truly believe that's what was happening. Yeah.
So it sounds like do you start most of your conversations going down the mast cell histamine route?
Yeah. I can't say 100% of the people have that. But because you have other symptoms of mast cell activation that come along, that's not related to the bladder. And that's part of the whole health history that we have to do when somebody first comes in and they do these comprehensive forms. I mean, they spend hours filling out forms for me. Yes, because many have allergies. Many have, even seasonal allergies. Many have food allergies. Many have skin issues, eczema, you name it. They have other signs of mast cell activation and histamine. So yeah, I do have that conversation with everybody.
Okay. So a lot of people, end up reaching out to you, and are most of the people that when they finally get to you, have they been through some conventional recommendations at that point, or done their own kind of trials on
Many
things?
Many have been through functional medicine.
Okay, yeah, I imagine.
And frustrated even with that too.
So I think this is a really good thing to highlight, because I think one of the complications or kind of downsides of functional medicine is the lack of prioritizing, where to start and, what's in. It's not like the recommendations overall are not good, but it's expansive, and everybody's applied, multiple different things, maybe all at once, and it's overwhelming. So can you talk about how you get people, like, basically you clean up the mess that's been done and kind of like reboot the process? Because at that point, a lot of people are just disenchanted, frustrated. I've seen a lot of patients just being like, they're just like, I don't think it's going to work. Well,
you know what? Here's the thing. I think the functional medicine providers, they mean well, but many are still in that Western mindset doing functional medicine. So a lot of them are coming to me and they've been diagnosed with Lyme. They've been diagnosed with Lyme co-infections and they're treating it. They've been diagnosed with mold mycotoxins and they're treating it. That my patient population cannot handle Lyme and mold treatments. They will fall off a cliff. They're not strong enough for that. And so I always tell people, we're not going to do that. We're going to build you back up. Build up your resilience using nutrition therapy. That's really what it boils down to. And when I say nutrition therapy, it's not just the food, because the food it's available, unless you have your own farm and you're growing your own garden and you have your own animals to kill, it's not very good quality either. You know what I mean? So it's going to have to be, and I always prepare people, you're going to be taking supplements. There's no way around it. Unless you like live on a farm and you are totally in control of what's going on your plate and you're not overcooking things and you're picking them fresh. Because, by the time food is actually on our plate and it's cooked, it's probably lost 50% of its nutrients. Then we overcook it and we damage it. So that's where I always prepare people, you're going to be taking supplements. But yeah, I think that's where it boils down to. We have to build you back up before you go after. And a lot of times, a lot of these infections, they resolve themselves once your immune system is starting to function better. So do I go after the mold right away? Because then they end up having the Herxmeyer and the die-off symptoms, and then they can't even function. And I'm like, I'm trying to improve your function. I don't want to make you feel worse. So I think that's where the problem is.
I like that. Yeah. One of my mentors, Dr. Lisa Altschuler, really promotes that approach too. It's like when someone's unwell, there's so much already stripped down and things being taken out, and it's a very sort of aggressive, dismantled state of the body. And if you, like you said, if you're spending time nourishing and building up and getting and strengthening versus further pulling things out or further disrupting the system, it makes a lot of sense, especially if histamine and mast cells are underlying this, right? Because like the nature of a mast cell is alarm, something's wrong, right?
Cell danger.
Cell danger. Yeah, there you go. It's cell danger. And so it makes sense that you're trying to support the system to stabilize first. I think that's really helpful. And, I think you can probably sense with the people who hear that message, sort of a breathing easier kind of moment.
It's a mixed bag, actually, because some people, they still want that quick fix, even though I'm telling them I'm not your quick fix. This is at minimum going to be a 6-month process. And actually for my own healing, it's been 3 years. Me, but I was very severe. and I have all the terrible polymorphisms. So I'm like worst of the worst. And if I can do it, you can do it, you know? So, but that's the conversation I have to have. And, you know, that's how we pre-screen some people, because we don't take every patient that walks into the door. I have to make sure that they're ready. And if they're not ready, I don't want to waste their time. Yeah. You know, so I have to make sure they understand this is not a quick fix. You might get worse before you get better. You know, the timeline's all different, and there's a lot of things that influence that timeline. Some of it depends on age, how long you have the condition, how complicated it is, and honestly, a lot of it has to do with their own accountability. Are you really following what you're supposed to be doing? How many times are you, you know, great example would be somebody who has gluten sensitivity, and you test gluten sensitivity, find out they have it. You find out that they have the genetics for it, yet they're still cheating. So that's all played into this timeline of healing.
Yeah, like I think that's good to establish those expectations in the beginning, you know, versus like telling someone, you know, it's like a 4-week program or what have you, and things will turn around. It's just really setting realistic expectations about the process of healing something as complex as this. And, you know, I do think if people get there and they're willing to do that, low medicine can really pay off down the road, you know. And when I say slow medicine, I don't mean it's like, you know, you're not doing advanced, innovative things. It's just that realizing that it's going to take some time and being engaged in that process.
I hope one day we can actually marry the two together, where you have the nutrition and whatever innovative, you know, there's tons of innovative things that are coming out, you know, peptides, for example. There's many things out there that can be really help, I guess, put fuel on the fire, you know, jumpstart and move things faster. I don't want it to be a 6-month process. I don't want it to take a year. I would love for it to be, you know, a 6-week, maybe 4-week. And maybe that's where the two together, you know, 1 + 1 = 3. When you put them together, you get even more. And hopefully at some point we can see that in our future, where medicine is embracing what we do and kind of incorporates it into the practice.
Okay. And do you see anything in your patients' background or their medical history or their lifestyle practices or risk factors or even like childhood trauma or anything that leads up to this presenting?
All of the above.
Okay, sorry. Didn't mean to answer the question.
No. It's, you said trauma, and that was one of the first things I will say. So that's kind of be a long-winded, because I find this very fascinating, actually. So we're dealing with a lot of women, although men can also have it, but it's 90% women. We have this presentation of type A personality, very driven. But almost too driven to the point where they are very hard on themselves. Expectations are very high. So there's a personality profile with this population. Family history wise, interesting. The cardiovascular piece of it to me is very new. I'm just learning about that with Ruth Chris, about the family history of cardiovascular disease and that hypercoagulation pathway. And the fibrin and the biofilms with the embedded infection. So that was really new. That's new. I don't have a ton of information on that. I'm just learning that one, but that's a new one when I'm like, oh, yes, when I do patient health history and I do family history, yes, about 80-90% of them do have the heart disease in their family. So that was one. And then many, maybe about 75% have had some kind of trauma. So there's childhood trauma, there's sexual abuse, there's physical abuse, emotional abuse, something that's, when I bring it up, we have tears coming down with many patients during that time. Bring that up. So a lot of that. And then as far as health history goes, many are C-section born. They have not been either breastfed, that includes myself. So mom didn't breastfeed or minimal breastfeeding. Lots of antibiotics as a child. So, you know, my generation, that's what we did. If you got sick, you were given an antibiotic. That was normal. So those penicillin, bubblegum flavored, you know, that's, you know, I always ask people, how many times do you think you've been on an antibiotic? And so many times. A history of strep throat. Many have had ear infections, tonsillectomy, you know, the whole childhood, but that all plays a role in a disrupted microbiome.
Sure.
So
What
all of
about,
that. And then also, sorry, the C-section I thought was really interesting too, because, you know, that seating, the vaginal seating is so important during birth. And you miss
right,
that opportunity when you do a C-section.
right. Yeah. What about atopic kind of history? I'm not quite sure if you were alluding to that, but like eczema, allergies, the kind of
Oh,
whole
yeah.
triad.
Yeah, not everybody. But yes, many of them have either environmental allergies, they've had skin issues. I mean, even food allergies that they know of. But not everybody knows, because sometimes with the food allergies, they haven't tested it. They kind of feel like they might have an allergy to something. Definitely, but not everybody. I think that might be more 50 to 60%.
Okay. And you mentioned temperament, like type A personalities. What about other like aspects of temperament, like sensitive, introverted, any of those kind of flavors to the population?
Most of my patients are very, very charming people, very charming. I say I could be friends with all of them. I literally can. I honestly feel they have this very strong affinity for people. They're people pleasers.
I see.
You know, yeah, it's really interesting. I don't see the introverted piece as much, but I think maybe they're extroverted introverts like myself. But definitely very outgoing, very yeah, I guess that's how I can explain it. I think that comes from that type A personality, because they really do, they're very driven, very, very driven people. And, honestly, very knowledgeable. When they come to me, they know so much already from their own research. They just try to put the pieces together.
Yeah.
Yeah.
Yeah. It's interesting, with, I think everybody has to be ready to confront the trauma piece. And it's definitely something that, a practitioner can't force upon someone, to go there, because it can be very disruptive in itself. So I think there's a way of bringing it up with your practitioner and exploring it and starting the process. But in my experience, I would echo that the people I've seen have had some type of patterns of trauma, chronic patterns, not necessarily just like a single event, but like a chronic pattern in their life, or certain trauma. And it makes sense from a stress HPA access standpoint. It makes sense from a standpoint also of like just mast cells being on alert.
Yeah. And also disrupted immune system.
Right. Yeah. Good point. Yeah. So since the gut is a foundational piece of what we think is driving it, can we walk through a little bit of how that might be happening? Just in your mind, when you're reverse engineering sort of, I'm happy to know that you're an engineer, because it gives me an insight of how you think. I was raised by an engineer, so it's something I was innately trained to think this way. But like, if you were to reverse engineer, how the gut might be involved with creating this inflammatory environment, how would you see it happening? Or you probably know, but I would just love to hear kind of how the models you use in your brain to think about that, the connection.
Well, considering that many of the patients, and honestly, Americans have been exposed to things that damage our microbiome. So again, going back to if it's starting from birth, or whether it's throughout our life, or even just eating the food here, like the pesticides, we have to think about restoring homeostasis from that perspective. And it's not an easy thing to do. And it's also not necessarily going to work for everybody, depending on how much damage is done. I mean, you probably have heard about these fecal transplants that people have to do, have really serious conditions. I think that's a last resort, honestly. So I have to first find out from their history where it's been, what you've dealt with. What does your diet look like? Because 9 times out of 10, they're not getting enough fiber in their diet to promote good bacteria I don't do stool tests on everybody. I used to. I used to use the GI map, and I just didn't find that helpful for a nutritionist. I felt like that was more diagnostic. You want to go on some kind of medication, and it wasn't giving me functionality. But the stool test that I have done, BiomeFX through Microbiome Labs, which is more a functionality test, I have seen some very interesting things, and just some things as simple as too much protein, not enough fiber, not enough plant-based foods. Now that's tricky, because then you have to think about the oxalates. So I think it's a web. Okay, it's all a web. And I think what happened was, you had the childhood health history, disrupted microbiome, reduction in lactobacillus, because they're very sensitive to antibiotics. You get the gut inflammation, damaged bladder epithelium, leaky gut, intestinal permeability. And then comes the other issues. Diamine oxidase levels have probably become a problem because you're not producing them as well because your gut lining is damaged. So there's a histamine. And then the oxalates, that's where I think is really, I still think a lot of IC practitioners still don't understand how this is all happening. And the oxalates, I think, are really tying it all together as far as the, not just the damage to the bladder, but also the damage to the gut, because these little crystals can really damage the tissues and really just hijack your entire system. And I think what's happening with that is because the gut's already compromised, I can't tell you that everyone's on a high oxalate diet. Some of them are. Some of them are because the food industry tells you that that's good for you, right? Like, oh, juicing, spinach and juicing celery is the way to optimal health. But that's not really what most people are doing. I think most people are actually just hyper absorbing whatever oxalates that they're eating. And they're also producing oxalates endogenously. And now you've got all these oxalates that are kind of free floating in the gut. They're embedding into the tissue. They can just damage and shred the tissue on any level, anywhere in the body. And so that's why I think when I have to reverse engineer it, we have to start with that. First, let's look at your diet. Are you loading and pounding down oxalates? I will tell you, like I said, it's not everyone, but remember the patient profile I just told you about. Type A personality. Right? Many of them take really good care of their body. They're working out, they're really care about what they look like. Guess what? They're juicing. That's a good percentage. Not everyone, but that's a good percentage. So first I have to start with that. You've got to stop the juicing. Let's start with that. So let's start to reduce the amount of oxalates in your diet. Let's start to reduce the histamines in your diet as well. So we can kind of calm down the inflammation and kind of help restore the microbiome, because your microbiome depends on the food you eat. If you're eating a lot of oxalates, guess what? You're going to have a lot of oxalate degraders in your gut.
Right.
Enterococcus, also E. coli. There's a bunch of interesting bacteria that we are finding are part of these embedded infections in the bladder. When they do the PCR testing and they find out that there's enterococcus, that was me. I had enterococcus infections every time I got tested. It was enterococcus. And guess what? That's an oxalate degrader.
Yeah. I didn't know that. Yeah. The only one I ever hear mentioned is Oxalobacter. So I didn't know there was other.
Oh, here's an interesting one I learned about that guy. Yes, that one's very sensitive to certain antibiotics, primarily the tetracyclines and the ciprose. So that one is very sensitive to antibiotics. And yes, it is an oxalate degrader. Here's the thing that you probably didn't know about Oxbacter. Oxbacter does not like a high oxalate environment. It doesn't thrive in high oxalate environment. It thrives in a low to medium oxalate environment. So what does that tell you? It tells you that as humans, we were not supposed to be eating a lot of this. It wasn't. We weren't even evolutionary designed to be juicing. We were hunters and gatherers. We were fasting. We weren't eating constantly. We had feast and famine, winter metabolism, summer metabolism. If you're familiar with Dr. Neil Nathan, he talks a lot about the winter metabolism.
Love that.
Metabolism.
Yeah.
And so we're supposed to fast. We're supposed to take breaks from eating. We're supposed to change our diet seasonally. We're not supposed to be juicing constantly. Where did that come from? We didn't have blenders back in, our ancestral times. So I feel like we're causing the problem in some ways, and in some ways is not fully under our control, and it's just becoming this weird web that's happening. But I truly believe that is really an underlying problem for people. I don't think just IC. I think even IBS and a lot of other autoimmune conditions, I do believe there is an oxalate component to this.
You were saying when we were talking offline that you are starting to really understand genetic risk factors as far as polymorphisms that set up someone at risk for issues with degrading oxalates?
Mm-hmm. Yeah, so not necessarily, no. So the oxalate piece of it, interestingly, is not that endogenous one where if you have the type 1 hyperoxaluria, that's a very small percentage. That's not really everyone. It's maybe about, as far as my patients go, 10 to 15% have a SNP in that, a SNP, whether it's 1 or 2 copies. No, that isn't what's going on. This is more a combination of overabsorption of oxalates from your diet. So either, and this is why this is so individualized, right? It just depends on each patient. So it could be somebody who, some of my ladies who have been juicing for, 5-10 years, trying to manage their weight or trying to stay healthy. Okay, that's problem number 1. Problem number 2, we have the gut problem where they're overabsorbing any oxalates because they're not metabolizing their fat appropriately, right? Think about it. Bile, I mean, you probably see it in clinic. How many people have poor fat absorption? They're not producing enough bile. Maybe they have their gallbladder removed. Maybe they have poor lipase, just their digestive enzymes because of the gut damage. So they're not breaking down their fat. So what happens? The fats create soaps in the gut, and these soaps tie up all the minerals that are supposed to bind up oxalates to help excrete them. But now that's not happening anymore because you've got them tied up by these fats. And so the oxalates kind of sneak in and they kind of pass through and get absorbed more readily because of this problem. So that's another issue. It's a lot. It's a lot going on. And then as far as SNPs go, the only one I can say that might be related to oxalates might be, or related to the immune system that I see a lot, could be the IL-6, interleukin 6. Depending on how many of the polymorphisms they have there. That interleukin 6 is very strongly, the inflammasome oxalates can really push that inflammasome pathway, and that's the IL-6. And so then we're having that whole mast cell activation that way. So you have oxalates, IL-6. If you have a SNP or you have several SNPs, then boom, we're more likely to go down that.
Okay. Well, before we leave the oxalate conversation, I just want to comment or ask a question. Does the pushback I usually get when I hear about people, sort of confronting a potential oxalate issue is like, I don't want to be a carnivore diet. I don't want to go on a carnivore diet.
I agree.
Is that sort of like an extreme version of a low oxalate diet, and there's something more in the middle?
There is definitely something more in the middle. I did want to mention just 2 more SNPs. I was just thinking when you just brought this up, sulfation. So we do have a lot of people who have the sulfation. That's another issue with oxalates because a sulfur exchanges with oxalate directly. Okay. The less sulfur you have, the more oxalates you're going to absorb. Wow. So that's an important one. And then the last one is the PON1, which is the glyphosate piece. So glyphosates, I don't know if you know this, your Roundup, the glyphosate can actually convert to oxalates because it ties up your glycine as that glycine substitution, and now you're not gonna have the glycine available to metabolize your oxalates, and so the glyoxylate becomes oxalate. So there are other things going on there. But back to your question on the carnivore, I do not promote the carnivore diet. I think going back to gut health, you're asking for a disaster in your microbiome. Again, so with the microbiome, biome effects, we have 2 areas you can look at: proteolytic fermentation and saccharolytic fermentation. So saccharolytic is your carbohydrates and your fiber. Proteolytic is your protein. And this is going to get me chastised by the carnivore community. What I'm about to say. But I'm okay with this. I'm okay with this because, I have a lot of carnivore people who follow me. Yeah. And they think I'm a carnivore dieter. I'm not. Yeah. But I think they think that because they think low ox means carnivore. No, that's not what it means. It means being really strategic at the types of plants and making sure that you have what's called diversity in your diet. So what I have done is I've taken Deanna Minich's rainbow diet. I don't know if you know Dr. Deanna Minich. Yeah. Are you familiar with her? Oh, yeah. I'm a big supporter of her work. I just think she's amazing. I love her. And she had the rainbow diet, and which I thought was fabulous. I'm like, this is great. But it's not catered for the people who need to be low ox. So I revised it. So I created the rainbow diet for IC. And I prescribe that to my patients. So what I have them do is, well, first we have to find out what's the diet looking like. And truthfully, most people don't get enough protein in their diet anyway. So yes, I don't like the pendulum going either direction. I'm a middle ground kind of person. I believe in middle ground. Extremes are never good.
Right.
So let's see. Most people don't get enough protein. So we do initially increase their protein intake. We do. Why? You need amino acids. The amino acids are important for your immune system. Okay. So we have to increase the protein. So what I've done is I've taken the rainbow diet and I have people draw the plates, and we'll do the plate where about half of the plate, we'll just do the lean protein. So that can be chicken, fish, which most people don't get enough in their diet.
Mm-hmm. For sure. Yeah.
Omega-3s are down.
Yeah.
So we have to get the fish, the chicken, grass-fed meats, organ meats when you can, although I have mixed feelings about the organ meats. And then we'll have the other side, which is your plant-based. And so I have them do about 30% of their plate is fruits and vegetables. And that's where I give them the rainbow diet food list that has all the different foods that are low oxalate, that are colorful. So what I have them do is I give them a tracker, and they have to track how many colors they're eating in each meal. And I try to tell them, like with each meal, if you can get about 5 to 6 colors, you're in a good situation. So try to get 5 to 6 colors, and that's actually really good for your immune system, because if you think about it, not only are those little phytonutrients are communicating with the cells of the immune system, that's one thing, but the other thing is when you have food allergies and food intolerances, you're introducing less possibility that you're going to react to that because you're eating less. So instead of doing, because a lot of Americans, though, their vegetable is a cup of broccoli, and that's the only vegetable they have all day. So I'm saying, no, we're going to do a quarter cup of broccoli, a quarter cup of onions, a quarter cup of mushrooms, a quarter cup of red peppers, or yellow peppers. You're going to diversify, and you're doing less. So if you had a food sensitivity to that, it's such a small amount, you're less likely to provoke that immune response.
Yeah, makes sense.
So it's better for people who have food allergies.
Yeah, that makes a lot of sense.
And then the last piece of it, the other 25%, is starch. And I find starch to be a nice to have, not a need to have. And this is the question I always ask people. Are you training for a marathon? No. Do you work out 2 hours a day? No. Then starch is an energy form of food. It's a storage form of food. It's, potatoes are given to people to give them a lot of energy, or pasta to prepare for a lot of activity. If you're inactive, you don't need a lot of starch in your diet. So that's a nice to have, not a need to have. So that's kind of how. Yeah. It feels more like a dessert now to me. And I think people eat, I think like the American diet is protein and starch. It's like a steak and a potatoes. Yeah. And so we have to re-look at how that is. And that plate is just temporary. I'm trying to move them towards where that half is the protein. Maybe after a year, they switch it where that half is the fruits and vegetables, and the protein moves over to the smaller 25 to 30%. I don't want them to be on that high protein long term. Unless they're advanced age. If they have advanced age, then they do need more protein. But if they're not, then we want to eventually move them so the majority of their plate is fruits and vegetables, low ox, and the protein is back to its normal amount. There's also issues with digestion, right? So they have to optimize digestion, make sure they're digesting the protein appropriately. They have enough stomach acid, things like that. Yeah, I like that. So, it's very phytonutrient rich, and the nutrients you're selecting have a lot of healing properties and balancing properties and repair properties on tissue. And, getting away from this, like a superfood in its nature, it's kind of like that's probably pushing the body way beyond what it's accustomed to handling, with even just like a super shot of excessive phytonutrients all at once. It's, so it's nice to hear that you're kind of like bringing it into a balance that the body can actually tolerate, especially if someone's already dealing with inflammation. Yeah, and the carnivore diet, I think, is another fad, just like Atkins was, and I understand the rationale behind it. I think it has helped a lot of people, and so if somebody wants to do it for a few months to help bring balance back, that's fine. I don't have a problem with that. But long term, we're thinking about that proteolytic fermentation. You're thinking about dysbiosis, and you're thinking about colon cancer. And that's when I think of too much meat, I think of colon cancer. It's the first thing that pops in my mind. Yeah. So I'm not going to promote that. I think when we talk about ketogenic dieting, I think that's helpful for a small percentage of people, especially, if they already have neurodegeneration and they're not optimizing their glucose usage into the brain. They maybe have brain inflammation and they just can't use the glucose properly. Then ketogenic diets can be helpful. Again, that's a small percentage of the population. That's not my population. So,
yeah. And I always, sort of reflect back to the patient, if they've gone on carnivore and they feel amazing, I'm happy they're getting a break. And I usually just highlight the fact that every kind of diet where you kind of pull levers back has its moment. It's like there's a moment where it will shine. And then I'm always, sort of like encouraging people, what's going to be the sustainable, nutrition plan for, something you could see yourself staying on for life, and
balance.
Yeah. And so it's like, I think it's important to validate that, yes, people might get amazing results for a period of time. And, that's not in their head or anything. They're actually, probably pulling back on the brakes on something that was flaring them up. And then, but, there comes a point where the laws of diminishing returns might kick in.
Agreed.
So, well, that was really helpful. And I know, like, this has been really good, just kind of getting the foundations of your philosophy and approach. And then I know, after following a lot of your YouTube videos, which are amazing, by the way, I just love the education you do. It's, I think anybody who's listening to this should really make sure that they link up with you on your YouTube channel and see all the great work that's out there. But I know that you go into some other threads that you've mentioned a little bit about mycotoxins and fungus, and I'm not expecting you to kind of unpack all these areas, but how do they fit into the construct of when people should be thinking about these problems, and are they actually relevant?
Yeah, I mean, if you live in mold and you do, and your house is musty and you see it crawling on your walls, you better figure that one out, because you will not get better if you're living in that. I don't care who you are. That right there is, I mean, forget IC. Let's talk cancer, right?
Yeah.
It's carcinogenic. It's very disruptive of the immune system. So I think that's kind of, I have patients who lived in mold, but they no longer do, or they say they don't, so, the mycotoxin health test is helpful because it identifies the amount of burden that is on the body. I find sometimes people, there have been a small percentage of people who either didn't show up to have any mycotoxins, and I think that's an excretion issue, or they have low levels and they're still having symptoms of mast cell activation. And I think that's where we have to bring in that whole cell danger response problem. Okay, you are in cell danger. You've been in cell danger for a long time. How do we quiet that down? So when someone has had exposure to mold, there's so many different combinations of symptoms and presentations. And depending on their situation, they might need, well, first of all, if they're living in it, they either need to remediate or they need to get out. So that's number one. Number two, if there's actually mold and they're high and they also have it colonized in the gut, which you can do some testing on to see, that it may need to be treated, with, gentle antifungals, I say. It's later on, after we've built up the immune system and we've done the foundational work. And I always say, you don't build a house on a weak foundation. You build a house on a strong foundation. So let's build up the foundation. And then as the pyramid goes up, you can do mycotoxin, you can do mold detox at the top. And there's herbs they can take. There's drops, there's herbs, there's different antifungals that are natural that they can do. And then the other piece with that mold is, well, if you're in cell danger, and even if you treat the mold, why are you still inflamed? Well, then that's when I have to recommend other modalities that are not nutritional, such as frequency-specific microcurrents or EMF or peptides. There's different things out there. Now, peptides, I can do peptides. We could obviously do that as a supplement, but sometimes people like to do the injections. So I do have to refer out depending on what I find sometimes in the later stages.
That makes a lot of sense. So I think we've really done a great job today, just really starting foundational work. And I think this is hopefully the start of future conversations on the podcast with you, because I think there's just so much to share. And down the road, as you're continue to go deeper into these topics and learning more and more. How would someone get started working with you, or at least kind of get in touch with their work? I know I'm going to be putting some links in our show notes, but I'd just like to kind of hear what you're up to right now. Are you doing anything specifically or special that people should know about?
So I'm still, I do take on patients. I did just accept a position at a college to teach nutritional biochemistry. So I do teach also part-time as an adjunct, which I love. I think education is, I always tell my patients, you're also going to feel like you're going through school when you're working with me. Because, the word doctor means teacher.
Right. Yep.
Right. It comes from the root word to teach. So if I haven't taught you something, when you've come out of here, I didn't do my job.
Yeah.
So that's part of, the experience of being with IC Healers. You also get a lot of learning and education. And yes, we are accepting patients again in January. I did close my practice down in December. Just got real busy. And so we are accepting that. And also, I do have an IC Healer course. I don't think a lot of people know about it. It's on the website. It's a self-healing course. If you're not ready to do any lab testing, you're not really dive in that deep yet, but you just kind of want to know what we're doing, we have a course on the website. It's called the self-healing course. I have 2 courses now. I have that, and I have the end chronic pain course, which is more about oxalates and mast cells and histamines. So that's more geared towards that piece. And then the IC Healer course is kind of like the full course about just all the different pieces we just talked about. I kind of go into, the role trauma plays, stress, the gut. We have a gut health, exercise, stress management. I have the 8 known causes of IC is what I created. The 8 known causes of IC, and I go into all those causes in my course. So.
Great. And I'm sure you have lots of stories of people who've got their life back, and a community of people that have gone through your program. So. I think it's really great for people to link up with someone like yourself. And I think it's one of the most valuable things about getting good information is it's just, you can't underestimate the value of a good plan, and also clarity and, understanding, because it's so empowering when a patient finally feels like they have a plan that they feel good about, and they feel clearer about what's going on with them. It's like you can see that this is leading somewhere versus just sort of being in a disarray of confusion and desperation.
Well, in my office, my normal office, when I'm there, I have a sign behind me that says hope.
Yeah.
There is another area that's not really looked at by medicine. It should be. It's the power of the mind and the power of hope. And you see this with the placebo effect all the time.
Yeah.
When somebody believes that something's working, it's the placebo, but they're still getting the results. Why is that? So there's a whole piece of it. And I think when someone signs up with somebody who has, similar background as us, and who can give them that path to healing, I think it really does initiate this feeling of hope. And that hope is carrying them through all of that. And I've actually noticed that there's a few patients who, before we even start protocols, before we even have started supplements or anything, within a month, I'm doing, because I do pain charts and I chart their pain over time, this drop in pain. And I tell myself, physiologically, is that really possible? Like, they haven't done anything. Could that be hope? Could be hope be driving that? And so then now, I'm thinking, well, there's physiology behind hope.
Absolutely.
So what role is hope playing with changing the physiology of that person?
Yeah.
Super important.
Well said. Yes. Well, if there's that's actually a really good way to kind of wrap up the podcast with that message. So I appreciate you doing that, and we'll make sure that all the links to everything we mentioned and to your YouTube channel and all your programs are put in the show notes. I just want to thank you so much for your time. I know you're really busy, and this has been very helpful. So thanks for being here today.
Thank you for having me. It's been a pleasure.
You're welcome. Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from that. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing podcast. And again, much appreciation for you being here with me.